All right, let's go ahead and get started. Before Deb leaves. So hello everyone, welcome. Today's talk is by Deborah Woodcock, and it's my privilege to introduce her. I mean, pretty much everyone knows Deb. Right now she is a clinical analyst for our clinical informatics group, but she's worn many, many hats in DMICE. She's a master's student and presenting her thesis today. But she's also been a program manager for the IDL, the Informatics Discovery Lab. She's TA'd many courses, including a course I'm teaching this term. And before she came to DMICE, Deb has a bachelor's with a double major in physics and astronomy and an MBA, and she's collecting many, many degrees. And is well on her way to her master's. So with that, let me turn it over to Deb Woodcock, who's going to be presenting her research today.
Thank you, Dr. Mohan. And it's great to see everybody here, particularly since there's no pizza being served. I appreciate everybody. It sounds like I'm getting a little bit of an echo, Nick. Is that all right? Great. So again, thank you, and thank you for coming to hear me talk about my thesis proposal, my master's thesis proposal, which is titled Effects of Medical Scribes on Patient Trust. In a nutshell, over the last 8 years or so, there seems to have been a great increase in the number of medical scribes being used in healthcare. And a medical scribe is an individual who comes alongside a provider and helps them document in the electronic health record during a patient encounter. Despite this increase in the number of scribes, there's not very much known about the effects of scribes, particularly on patient care and particularly from the patient's perspective. And as a result, healthcare organizations and providers who are using scribes don't have a lot of guidance in terms of how to use them effectively, how to avoid problems with them. And so I thought this might be a really interesting area to look into, particularly on the side of patient care and from the patient's perspective, because those seem to be gaps, and I'll get into those in a minute or two. So scribes have actually been used for thousands of years to document medicine. This is a shot from something called the Ebers Papyrus, which is among some of the oldest medically preserved documentation, and it dates from about 1550 BC. Fast forward to today and a busy emergency department. The first references to medical scribes in modern medical literature occur in the 1970s, referring to scribe systems used to document in paper charts in emergency departments. Today, scribes are still widely used in emergency departments, this time documenting in electronic health records, and they're also used in outpatient settings and in specialties such as orthopedic surgery, where documentation time competes with time that could be used on potentially very lucrative revenue-generating activities. So I thought we'd play the Where's Waldo? So can you spot the scribes in this picture? And actually, I don't know for sure that these are scribes, but if they were scribes, this is where they'd be located. And so you can start to get a sense for some of the challenges that might be involved with scribing, particularly in an environment like this. So a little bit more about the roles of medical scribes. What scribes do varies greatly from organization to organization, even within organizations, by department to department, and by provider to provider. But in general, medical scribes participate with the provider in preparing for the patient visit, usually reviewing the patient's information in their chart in the electronic health record. Then they accompany the provider into the room, and they document progress notes, and you can see some examples here of the kinds of things that they document during the visit. And they may help find information either within the patient chart that might be in a different encounter or in a different part of the chart, or external to the patient chart if the provider needs information during the visit. After the visit, the provider and the scribe typically confer, and if there's anything additional that needs to be documented, the provider will tell the scribe at that time. And then the provider reviews, corrects if necessary, and then signs off or attests to the scribe note. And this is actually a little screenshot of the bottom of a scribed progress note showing the attestation, and the signature of the provider would ordinarily go down here underneath. So, as I said, the number of scribes appears to be growing pretty rapidly. This is not a chart of the scribe growth. This is a chart, obviously, of EHR adoption rates in the United States over the last, well, it's 2010 to 2015, so for that period. But a scribe advocacy group estimates that in 2015 there were 15,000 scribes in the United States, and the same group estimates that by 2020 there will be 100,000 scribes in the United States. So again, take it for what it's worth. It's from a group that promotes scribe use. So those statistics or those numbers may be, taken with a grain of salt. But the growth may be associated with this increased EHR adoption rate. You can't obviously prove causality there, but we do know that EHR adoption results in both benefits and unintended consequences. So looking into this a little bit further, when you talk about the addition of the electronic health record to the patient encounter, for thousands of years, again, we've had this relationship between the patient and the provider in sort of a dyad. And yes, the provider might have been documenting on papyrus, or they might have been documenting in a paper chart, but fundamentally, the provider was focused on the patient. With the addition of the electronic health record, we've now moved to a triad, where the provider is not only interacting with the patient, but they have to interact with the computer. And as you can imagine, or as you can from your own experience, the experience of chatting with somebody and writing is very different from trying to talk with someone, have a meaningful conversation, and be looking for information in the computer while you're having that conversation. It requires providers to engage cognitively in a way that they've never had to engage before. And that's led to, as I said, numerous well-documented unintended consequences. For those of you who have not seen what a provider might see when they open a patient's encounter, here's one. There's no PHI in this. This is actually off of Epic's, one of Epic's environments hosted on the internet. But I wanted to give you an idea of all the things that they might have to look at. There's guidance up here and menus. There are menus down here, which have been actually recently greatly simplified. There's all kinds of information in tabs up here. Depending on what selections you make, other information appears. And so the provider is trying to speak to the patient, understand their problems, and assess the situation and do clinical reasoning. At the same time, they're having to use cognitive energy, if you will, to think about where they're supposed to be in the chart and what's going on. So the use of the electronic health record and this lack of usability, if you will, and the fact that it's not something that's easy for a provider necessarily to use, leads to several things that are really frustrations for providers. One is that it increases charting time on the order of hours a day. Instead of going home at the end of the day and finishing your paper documentation, providers often have to spend hours afterwards continuing to find what they need and document in the electronic health record. As I mentioned, as you could see, there's also the distraction factor, right, of having to do that. But there's also this issue of the physical barrier that the computer creates between the patient and the provider. Even if the computer isn't literally between the patient and the provider, as in this drawing, you can see, this illustration, you can see she's off to the side. And I like the fact that the provider's hair is a little bit untidy, and she's sitting sort of to the side. She's half facing the patient, half to the computer. And the very sort of trim and pulled together patient is leaning forward in anticipation, trying to get the provider's attention. This is one of my favorite illustrations because I think it captures some of those challenges and those subtleties very nicely. So it's not perhaps surprising that many providers have turned to medical scribes as a way to mitigate some of these issues around the time it takes to chart, the distraction, and the interposition of the computer between the patient and the provider. Because if the chart is being taken care of by the scribe, then the provider is free to focus more fully on the patient and their needs. That said, implementing medical scribes is not without its challenges. One of them is that because the scribe industry has grown so quickly, it is not there's great variation throughout the industry in many different areas. One is this idea of what is a scribe's role. And here you can see two definitions by sort of the big gorillas in healthcare, the Joint Commission and their definition of what a scribe is, and then the Center for Medicare and Medicaid Services and their definition. And you can see that those two definitions don't even agree. There is no overarching regulation or oversight of the scribe industry, and there also is no standardized training for medical scribes. And the net result is that healthcare organizations and providers are essentially left to recruit, train, and operate with scribes any way they see fit, because there's nobody setting any boundaries for them. So that might raise some concerns. So coming back to our triad with the computer, now in an effort to mitigate this interaction, we've added the scribe to the encounter. And as you can see from the thinner line here, yes, you may have reduced the provider's interaction with the computer during the encounter, but you've added another interaction here. You've added the interaction between the provider and the scribe. Just by virtue of the presence of another person in the room, there is an unconscious as well as a conscious need to engage with that person. So you've added complexity to this system in an effort to try to mitigate this issue or the issues posed by that relationship. So, as I said, when a scribe enters the room, they become an actor in that encounter, and they may alter the way that communications happen, even though they're not interacting directly with the patient, because they're demanding some level of attention from the provider in order to do their work. They will affect the way the provider interacts with the patient as well. So some suggest perhaps that having a scribe in the room might inhibit patients from talking with their providers, particularly around emotionally or physically sensitive subjects. And some suggest that the scribe may actually enhance the patient-provider relationship. There's really no evidence out there, and nobody has really studied which, if one or the other, or a little bit of both, that might happen. So that made me wonder whether the effect of the scribe on this interaction and on the trust that patients have for their providers might be affected by introducing a scribe into the encounter. So let's talk about trust for a minute. While there are many types of trust and many definitions of trust, it's widely considered that interpersonal trust forms the basis of the relationship between the patient and the provider. And it has been shown that higher levels of interpersonal trust can actually affect patient outcomes and also processes such as increased adherence to medication and improved glycemic control. So there's a good basis for trying to encourage trust and support trust in the patient-provider relationship. Closely related to the concept of interpersonal trust is this concept of collaborative trust, which has become more prominent as patient engagement and patient empowerment has become more important in healthcare. I really like this. I really like this photo a lot. The definition here is from Carol Bova, who is an investigator at the University of Massachusetts, who looks at who studies patient-provider trust, particularly in diverse patient populations and also on care teams that involve multiple types of providers. So not just physicians, but also nurse practitioners and physician assistants and so forth. And so I got interested in her work because she was taking a little bit broader view, and since I'm interested in studying scribes, I thought this might be a promising direction to, promising information to look at. So Bova suggests that you could look at this collaborative trust conceptual framework as comprising 3 elements. And I'm going to read a little bit from her definitions of them because I think she does a nice job. Interpersonal connection, which relates to the emotional bonding, which occurs when patient and provider demonstrate caring, sincerity, and the ability to relate to one another. Respectful communication, which occurs when patient and provider demonstrate respect for each other and protect confidentiality and privacy. Professional partnering, which involves sharing knowledge in a way that's understandable, demonstrating commitment to the relationship, and reciprocity between the patient and the healthcare provider. So again, by virtue of their presence in the room, it would seem to me that the medical scribe has the potential to affect any and all of these elements, and it suggests that it may be important to understand how the introduction of patient scribes into clinical encounters may affect collaborative trust. So taking a step back, let's look at what's already been studied about scribes and put it in context. You can see my search strategy here. I won't go through it line by line, but essentially I searched on the terms medical scribe or team documentation, which I'm starting to see more frequently now in the literature. I didn't constrain it by dates, and I did reference chaining, so as I started to identify pieces of literature, I started to look at their references and work my way back through to find additional articles of interest. And out of that, in the period from 2008 and 2017, I was able to identify 26 published studies on scribes. And this is just a chart that kind of gives you an overview. The takeaways here are that the majority of the studies that have been done thus far have been, first of all, in emergency departments, which is no surprise given what I said earlier, and also focus on quantitative or operational financial metrics, primarily. And the areas where there are some gaps or there hasn't been a lot of work is in outpatient or ambulatory clinics, and also on some of the more qualitative aspects of scribes, such as perceptions of scribes from various populations. And so it struck me from looking at this as though this area, this general area of this matrix, might be an appropriate area to focus on, taking a more patient-centric view and also looking at something that, looking at an issue that is more related to care, the actual provision of care. Which brings me to my project goal, which is to explore the effects of medical scribes on patient-provider trust in an outpatient setting from the patient's perspective, using BOVA's collaborative trust framework as a guide. And there are 4 specific aims that support that goal. The overarching aim is to identify variations in patient-provider trust and patient perceptions of scribes between patients who have participated in scribe-assisted encounters and patients who have not. And so you can see that the sub-aims there are to first describe the characteristics of scribe-assisted encounters. How do they differ from non-scribe-assisted encounters? To examine the relationships between overall patient-provider trust for scribe-assisted and non-assisted encounters. And we'll talk about how we're going to go about doing that in a second. And then to examine the relationships between patient perceptions of scribes and patient demographic variables. The study design, since we don't know a lot about this space and we're still trying to figure out what's going on, is exploratory and descriptive. I propose to use mixed methods, so a mix of qualitative and quantitative methods to do this study. When you're looking at a new phenomenon or an emerging phenomenon, and I would propose almost anything, it is valuable to look at it from multiple perspectives and using multiple methods. You'll get richer data from that. You'll be able to see where there are intersections and triangulate on that information, as well as seeing kinds of things that pop up using one method that maybe didn't emerge from using another. Again, the study is patient-focused. We're going to look at a series of snapshot encounters, so I'm going to study one patient encounter at a time. It's not longitudinal, it's singular. And then there will be 3 stages of the study. One is preparation, because I don't know what I don't know right now, so I'll spend some time trying to figure out some of that before I get going. And then data and collection analysis, which I'll go into in a minute. You'll see the 3 pieces of that. And then finishing with evaluation. Now, this chevron diagram is a little bit misleading because in reality what I'll be doing as I learn things through this process is looping back and helping and incorporating the things that I learn into these earlier phases, because for example, I'll be observing a patient in an encounter, administering the questionnaire, and doing the interview all at one time, and out of that I may learn something that I can then take into the next patient encounter. So it's an iterative process, and it's a process really of discovery in order to support future hypotheses about what may be going on with medical scribes. The setting for the study I propose is one outpatient clinic that seemed to be most feasible to me, and the setting that I'm proposing is the Center for Women's Health, the OBGYN clinic. And as you can see, there are 6 different subspecialties or specialties in the Center for Women's Health. And as you might start to think about this and the kinds of patients you might have, you might think, well, you know, a general patient's going to be maybe a little bit different than somebody who's seeing a physician or provider for a pregnancy that's high risk. So we start to think about some of the variation that may occur based on the types of patients in our population. I liked this setting for a few reasons. One is that they have the greatest number of provider scribe teams at OHSU. So it's a rich environment and really could maximize the amount of data that I could collect. The other is that they were an early adopter of Scribes, and so they've had a fair amount of experience. Now, Scribes typically will cycle through the department, so there's always turnover, but providers at least have had familiarity, and administration has had experience working with medical scribes, and there's a lot of information and background to be mined there. Within OBGYN, OBGYN uses, if you'd like to call it, a student scribe model, whereby pre-med, pre-nursing, and pre-PA students come in and work for a year or two, and then they cycle out and they go on to graduate school, they go on to med school, they go on to nursing school. In the meantime, they've gathered really valuable experience and contacts in the environment, and the environment, the clinic, has gained scribes who are very invested in what they're doing because they know that this is part of their future training. Within OBGYN, there's what I call a one-to-many provider-scribe relationship, which means that every provider works with a single scribe, but scribes may work with multiple providers in a sort of a pooled setting. And some providers don't use scribes, so this seemed to be a good setting to select. The participants in the study will be patients, providers. I anticipate encouraging 5 to 10 providers with scribes and 5 to 10 provider scribe teams to work with me on the project, and they will all be consented according to OHSU IRB protocols. With respect to ethics and integrity of the study, patient privacy is obviously a key concern, and if you think about the sensitivity of what goes on in OBGYN, you can see that it's very clear that I will have to be very respectful of my interactions with the patients, regardless of what the reason for their visit is, and be willing to step out of the room if they feel uncomfortable at all. The last thing that I want to do is have a negative effect on the patient-provider relationship myself. We'll talk a little bit about this issue of reactivity a little bit later on. You'll see that there's a component of interviews with my study, and those interviews will be conducted in a separate room. So again, trying to respect the patient's privacy. With respect to data confidentiality, I will be de-identifying all the patient data, collecting the data on a secure OHSU laptop, and storing it on OHSU's approved HIPAA-compliant cloud storage system box. So now let's dig down into some of the real meat and potatoes of the specific aims and the methods. The first aim, or 1A, not the overarching aim, but the first one under it, is to describe characteristics of scribe-assisted encounters. I propose to do this with 2 phases of clinical observation. Again, it's patients, individual providers, and provider scribe teams in clinic. And phase 1 of the observation will encompass about 6 encounters per provider for about 30 to 60 encounters, and another 6 encounters per provider scribe team for another 30 to 60. And the purpose, as you can see, is for me really to become immersed in and familiar with the OBGYN environments in which I'll be doing this study. Building rapport, both with the providers and the staff, because they're going to be seeing me around, and I want them to trust me and to feel that they can come to me and share information. And I'll start to become familiar. As I see encounters where patients where scribes are being used and encounters where they're not, I'll start to notice what those differences are. And all of that will help inform creation of the observation guide I'm going to use in the second phase. So during phase 2, which is really where I start collecting data, I am anticipating observing 6 to 12 encounters per provider for a total of 60 encounters. And I'll talk in a minute, I'll talk in a minute about why 60. And same thing for the provider scribe teams. And the purpose for this observation is really to capture the behaviors exhibited during these encounters based on what I perceive to be the important factors that are associated with these scribe-assisted encounters, and that I've created the observation guide around. In addition, there are always things that pop up that you don't anticipate, and that's some of the most interesting data that you collect. So I'll also be keeping unstructured field notes, and demographic information will also be collected at this point. With respect to data analysis, what I'll be doing is personally transcribing the field notes that I take and performing primary coding on the field notes. And typically when you read field notes or you read interview notes, you don't just read them once, you read them multiple times, because you may glean something new every time you read them. So you read them several times. And then once I've done that, because my perspective is only one perspective, what we'll also do is invite some subject matter experts, 2 to 3 subject matter experts, to come alongside and also look at the field note data and do some coding themselves. And we may use a card sort technique in order to triangulate and see if we come up with common themes and sub-themes by doing that. And that helps support the validity of this method. If it was just me, my opinion, that's one thing. When you have several people involved, you get at least multiple perspectives. You can't ever get all perspectives, but you get multiple perspectives. And then finally, what we'll be doing is, once we've come up with those themes, we'll be doing what is known as member checking, which is to go back to, in this case, the clinical informatics department and the Scribe program manager to say, here's what we're turning up. What do you think of this? Is there anything here that we should be aware of, or are there any subtleties that we're missing, because you're the expert in this area? Moving on to specific aim 1B, which is examining the relationships between overall patient-provider trust for scribe-assisted and non-assisted encounters. Again, same groups that I'm observing, and the purpose of this method is to measure the level of overall patient-provider trust. And we start to get this triangulation going, right? So we've done some observation. Now we're going to do something where we actually measure the level of trust for these 2 groups. And that helps us to triangulate on the data we've already collected and started to analyze. And I propose using a trust questionnaire that was actually Carol Bova's, that has been validated, and I'll talk a little bit about how it's been validated later, but I'll administer it face-to-face immediately following the observation. So the idea of the flow is that when a patient is asked at the beginning of their visit, when they check in, if they'll be told about the study, asked if they're interested in participating, and if they are, part of the condition, one of the conditions is that they're able to stay for 15 minutes or so after their visit to be able to have a conversation with me. And if they don't want to do that, that's perfectly fine. We'll go ahead and move on, okay? Okay, so data collection continued. So let me tell you a little bit about this validated instrument. As I mentioned, it was developed by Carol Bova based on her collaborative trust conceptual framework. It measures levels of overall patient-provider trust. So it doesn't have anything to do with scribes. This is just measuring baseline trust. It's been validated both for diverse care teams and patient populations, and I like that because we certainly have diverse patient populations here at OHSU. I don't know what I'm going to find in the Center for Women's Health, but it's conceivable. Oh, I can't believe I just said that. That the population that I study will be, the samples that I study will be diverse. And I will be administering it face-to-face, and it's nice that she had both validated it for face-to-face administration and self-report, so you could hand somebody a paper and ask them to send it in, and there was to be valid. You don't want to mix those two things within one study, but so we're going to strive for face-to-face administration. The survey itself or the questionnaire is 13 Likert scale questions, and one of the questions is reverse coded to again try to generate internal validity for the instrument. And it's scores of 0 to 52 and anticipate in less than 10 minutes to complete the survey. So BOVA has, in the development of this instrument, implemented it or administered it in a primary care setting. That's one of the things that we know about data that's already been collected using this instrument. And so what I'm doing now is I'm looking for clues that might help me think about how I might use this in an OBGYN environment. Particularly when you see patients in a general OBGYN setting where they're coming in maybe for annual well woman visits or more routine things. In many cases, women may view their gynecologists as their primary care provider. They may not ever see a primary care provider until some other kind of health issue crops up. So at least for a portion of the sample that I am anticipating recruiting for this study, that the primary care OBGYN connection it's plausible. You could make that. Maybe not so much with some of the other types of patients we'll be seeing, but I wanted to be very aware of what I was doing as I was looking at this primary care data set. Also have to be aware of the fact that she was using this data, or she was collecting it, in order to test the validity of her instrument, not to do the kinds of work that I'm doing. And so I have to be aware of the purpose behind it. Also, her data include female and male. In OBGYN, I'm going to be seeing female patients only. And I also know a little bit about the data. I don't know much about the distribution of the data, but I do know that the data are ordinal because they're scores based on this 0 to 52 scale, and that the mean was 45.3 when she administered it, with a median of 49. So that's a pretty skewed distribution to the right. It seems to suggest that people are generally more positive in their scores than negative. And as you can see, we also have a standard deviation here for the overall. Unfortunately, I don't have information yet on median or standard deviation or range for women only. I'm trying to get that information from her. And so if I do that, that will help me understand this data a little bit better. So how would I use this in administering the questionnaire? Well, first, I need to find two samples. One is patients who have just had a Scribe-assisted OBGYN encounter, and a group of patients who have had their OBGYN encounter without a Scribe. And that brings us to sample size estimation. So I'm going to unpack this statement a bit because there's a lot in it. So the question that I was trying to answer here in terms of estimating sample size, because I'm hoping to gather enough responses that I am able to run inferential statistics on this data, is assuming total sample size n, assuming it's split equally between the two groups. So I'm talking about two separate samples, two independent samples. How many subjects are needed to ensure an 80% chance, so I'm looking to power this at 80%, of detecting a clinically relevant difference between the medians of the two groups. Because it appears that we have a non-normal distribution, that implies that we may want to consider using non-parametric methods for estimating the sample size and for doing the data analysis. And when you do non-parametric methods, one of the things that you do is you're looking at medians. You're not looking at means, which you would be looking if you were looking at doing parametric work. So what is this clinically relevant thing here? How do we know it when we see it? there's a difference. A statistician might tell you this test or this process will allow you to detect a 1-point difference on your scale. Well, that might be great, but that might not be clinically relevant. Whether somebody scores whether the median is 49 or it's 50 may not make much difference to a practitioner who's looking at this material. So clinically relevant really refers to what is going to get someone who reads this study to sit up and go, oh, that looks like it might have made a difference. So as you're doing this estimation process, and you can't just run it through a calculator, an online calculator, and generate a two-sided t-test with non-parametric data, how do you figure out what an appropriate clinical effect is, and how do you factor that into your sample size estimation? So I consulted with an OHSU statistician, and the method that I'm proposing or have used here to estimate my sample size is based on numerous discussions with him and some additional reading. And basically the process is, first of all, is with all projects like this, you would start by determining your hypotheses. So your null hypothesis is that the presence of medical scribes, absence or presence, makes no difference one way or the other in the median of the trust score that you're going to see. Your alternative hypothesis is that the presence of the scribe shifts the median of the trust score a certain amount to the right. It becomes even more skewed. You lose some of the tail, but you gain more at the upper end of the distribution. So that seems to be a plausible approach to this. Then what you do is you approximate probability distributions for each of these hypotheses. So I'm going to jump right down here to the printout and ignore this 4 versus 2. We actually modeled 4 different cases at varying levels of probability, so that's an artifact from that. But if you just concentrate on the fact that this is the null hypothesis, you can see that first of all, we binned the median scores starting at 32 and running up to 51. And we put because we know that it's skewed to the right and there's not much of a tail. So, and 32 is well below both the median and the mean that we looked at earlier. So there's 10% in this bin, 10% in this, and then you can see the distributions start to go up as you move to the right. So this is you've got 70% here in the first 2 bins and the other 30% down below. And that produces a mean that was very close to what we looked at on the previous couple of slides as far as what Bova found in her primary care distribution, and a median of 47. Then we take this alternative hypothesis and we make some assumptions about what if the trust score, the median of the trust score shifts to the right, the distribution might look like then. And you can see now there's nothing down here in these first 2 bins in this tail, and we have shifted the distribution more to the right. So you can't, on the one hand, you can't just willy-nilly just pick a distribution. Well, you can, but you shouldn't. This has to pass the sniff test, right? It needs to be something that looks like it could really happen. But you're still making a guess in terms of what parameters you're putting into this program in order to generate your sample size. So what comes out of this is something called the p-order. You can see here it's 0.656, and the p-order is a measure, if you will, of the effect size. You're measuring the distance of this p-order from 0.5, which would be if there's no change. It's essentially your null hypothesis. So it's associated, if you look at the change in the median here, with a 4-point effect size. So, okay, hold that thought for a minute. And it produces a total sample size of 94 patients. That would be the total number. Split between 2 groups, that's what, 47 per group is what I would need to study. And after, as I said, we ran a number of these scenarios and simulations, this seemed to give us both a reasonable distribution of what the change or the alternative hypothesis would generate. It gave us a 4-point effect size, which, based on conversations, both with the statistician and with providers, seem to be an acceptable, that would be something that would get somebody's attention if the median shifted 4 points. And it gave me a reasonable sample size within which to work, as I don't have 5 years to do this study. So it's this balancing act, right, to develop your sample size. And I wanted to be really transparent with you about all of the underlying assumptions there. Okay, so now we have a number. Now, if you recall, when I talked about observation and interviewing, I mentioned that I wanted to observe and interview about 60 patients. And the reason I said 60 is that if we're looking at N of 47, I'm going to assume that there are going to be some patients that I observe who may not complete the survey. And so that 60 is a little bit of a buffer. There's a little extra there of 13 patients so that I can have a reasonable expectation of achieving the sample size that I need in order to get statistical significance on this. Okay, so moving along. As far as data analysis, I will generate descriptive and inferential statistics of the overall trust scores for each of the 2 patient groups using the Wilcoxon's rank sum test, which is the nonparametric equivalent of the 2-sided t-test, and I'll run it at a 95% confidence interval. We'll see what falls out, as well as descriptive statistics of the demographics for both patient groups. On to 1C, which is examine relationships between patient perceptions of scribes and patient demographic variables. Same groups I have observed and now administered the questionnaire to. Right after we do the questionnaire, we spend another 5 to 10 minutes and do another qualitative gathering of data to elicit patient perceptions of scribes and to triangulate the observations and the quantitative data, or the questionnaire data collected, in order to, again, add validity and richness to the description of what's going on with medical scribes. And if you recall, one of the steps during observation phase 1, or that preparation phase, was to develop the interview guide for this. Similar to observation, I will do transcriptions of audio recorded interviews, and then I will be doing the primary coding on this to identify themes and sub-themes. Then I'll bring in, again, a couple or 3 people who are subject matter experts in order to support the validity, help with the triangulation and the theme building, and then do member checking again with folks who have not been involved at that point in the research as a double check on what we're doing and make sure that we're not going too far off the rails. Okay, moving on to evaluation. So just to summarize, the data analysis outputs by specific aim are these qualitative themes around characteristics of scribe-assisted encounters, and similarly qualitative themes in 1C around the patient perceptions of scribes that come out of the interviews, the qualitative description of patient behaviors based on the characteristics that I identified in observation 1, and the statistics that I just went through for the questionnaire. And those will be pulled together into the final report, which will include essentially comparisons of all of these things. So I'll be comparing, I'll be qualitatively describing what scribe-assisted encounters, the characteristics of scribe-assisted encounters and how they differ from non-scribe-assisted encounters. I'll be comparing the overall patient trust scores for the 2 groups. I'll be looking for relationships or relationships between the perceptions, the qualitative data gathered during the interviews and patient demographics, and doing a comparison of the overall patient trust scores based on the 2 groups. Sorry, not on the 2 groups, but comparing those with the patient perceptions of scribes to see if there are any relationships that we can tease out there. I'm also considering doing a comparison of my OBGYN results with BOVA's primary care results. Again, we know that there may be some issues there, so stay tuned. And then finally, looping this all back to the reason that we're doing this in the first place, which is to be able to give Bud Garrison and Robbie Bergstrom some thoughts and some ideas and some guidance, much needed guidance about things that they may or may not be aware of when using medical scribes and looking at the effects of scribes on patient care. So a few obvious limitations. One site, so although very valid and very rich within that one site, you can't generalize that and say that that applies to all OBGYN clinics in academic medical centers. Female patient participants, so we're losing the male component of this. Obviously, the uncertainty of the probability distributions that are underlying the sample size estimation is a big factor when we're looking at the evaluation of the questionnaire results. And again, that Bova's results, her primary care results, may not be comparable to my OBGYN because of the variation in the patient populations. Challenges: gaining access to the OBGYN clinic, reducing reactivity during observation. So when you observe something, if I step into the room, not only is the patient aware that there's a scribe there, they're aware that there's an observer there. And I discussed this with OBGYN, and several folks have indicated that because we're a learning institution, patients, particularly on return visits or who are seeing providers where they've already established care, don't think that reactivity is going to be a huge issue, but you have to be aware of it. Achieving sample sizes needed for the questionnaire statistical significance is also potentially a challenge if I don't even make those 60 numbers. Still things we can do with the data, but won't be able to run these inferential statistics. And then always teasing out the confounding variables, because you measure the trust and you look at the scores, and how do you know that it's actually the scribe that's is creating the effect? It could be the color of the provider's skin. It could be the reason for the visit. It could be any other number of things. And so we have to investigate that and make sure that we bring those all to the surface. So that's my presentation, and so many people have already helped me with this. And I want to thank all of you, and again, want to thank all of you for coming and listening to me, and hopefully it was somewhat interesting. And I am happy to take questions. Yes, Ian.
So in your talk, you were talking about how you wanted to look at the separation of having scribe-assisted versus non-scribe-assisted. When you mentioned how the patient might not feel comfortable with having a scribe in the room, what about having like a live recording where there's scribes in a different room entirely, just being able to hear the conversations that are going on? I was wondering if you found any research on that.
There hasn't been. One thing I kind of glossed over, didn't get into a lot of detail in this, but that we do look at when we're looking at how scribes interact is that there are actually different models for provider-scribe interaction. And as I said, in general, the scribe accompanies the provider into the room. There are some circumstances that I know of where the scribe actually stays outside the room. The provider has the conversation, then comes out and essentially dictates to the scribe. What the scribe loses there is the ability to actually see what the interaction was, because they may pick up on things as the scribe that they may want to ask the provider about later. So that's certainly, or their telescribes is another mechanism that some folks are using. Even when you have the provider and the scribe in the room, thus far we've found at least two different ways of interacting. One is that the provider completely ignores the scribe and just focuses on the patient. There's no conversation between the provider and the scribe. Another is where there's interaction between the provider and the scribe during the visit. And that may, one of my working hypotheses, is that is a factor that makes a difference. I did some observation at one point and was very interested, and this just starts to give you an idea of how the observation guide will become developed. I noticed that there was, the scribe was not just focused at the computer, but really focused on the provider and at the patient. And although the scribe doesn't interact with the patient at all, there was a sense that I perceived of the scribe being very invested in what was going on. And so if you have that sort of, if the patient perceives that there's a level of engagement there, they may see that as a good thing. That may actually support trust. Or if they see that the scribe is kind of detached, that may make them feel something else. But that's a great question. There haven't been any studies that I have found thus far that address that that issue, but it is something, certainly it's a technique that is being used. Other questions? Yes. Push the button, please. Hold.
So my question is, you mentioned that you were looking at it as kind of a snapshot of encounters. Based on what you've looked at, what's your opinion about how trust changes longitudinally as a single patient has multiple encounters with the same physician and sees the scribe more and more?
That's a great question. It's really beyond the scope of this study, but that would be a logical next step, is to look at how trust changes over time based on the scribe, and based on the fact that the scribe may change, right? So you might go in as a patient, maybe you have an established relationship with a provider, and they're using one scribe on one day. The next time you go back, there might be a different scribe there. So there are, again, a lot of variables there. Thank you for the question. Dion?
But Deb, to follow up on that, how are you going to control for that as a confounder?
I can't. In terms of analysis, I think that some of that will be done as we're analyzing the qualitative data, and we're starting to, again, bubble up what those confounders are, and I think I'll be better equipped to know how to look at them. Do you have any suggestions for how I might do that?
I think the previous speaker question had, that's a huge thing as far as trust is concerned.
Yeah.
That's experientially, in the studies I've seen show it is. At a minimum, you need to collect, number of encounters, previous encounters, and get data on your confounders so you can at least say that the two groups were similar in their composition. That's at a minimum. Better yet would be is if you could stratify it so as you're selecting the encounters you're viewing, you could say, okay, I'm going to take and I'm going to make sure that 25% of mine are initial visits and 25% are people established over 4 years and that type of thing. Hopefully you can use your 30 to 60 that you're proposing initially, which I think is a lot, but that's
yeah, it is.
To try and establish some of those variables. But I think unless you do that, you're really playing a statistical.
Yeah. Yeah, it may be that I need to limit the patients to only those who have established relationships. We don't want potentially any new or folks who have seen the provider only once. Dave, Dr.
So this is a good discussion to have. So so first of all, I think my question is going to be about the mixed methods nature of the study. It's actually qualitative and quantitative. They're a little bit separated, but to address Dion's concern, you could look at doing some earlier qualitative analysis and using that to inform the data collection you do, more quantitatively to have in the mixed methods. However, I want to say that I think this is fantastic, and that you can't, it's almost like you're trying to see is there any signal there, not explain the nature of the signal. Right? And so I think that's okay. You're trying to understand this epiphenomenon, and so not being able to adjust for confounders is okay. However, measuring, as Dion points out, is going to be really important for anything you think may affect it. And I might recommend that one of the best ways to approach that is in your early analysis, as you've gone through a set of encounters, but before you've done the rest, you have some early analysis to understand what you're starting to see, and then feed that back in to sort of how you're collecting information, because that can really bind the quant and the qual together to make it truly mixed methods.
Thank you. And making that qualitative, quantitative connection I'm struggling with that a little bit right now. So yeah. Dr. Mohan, did you have your hand up?
I just wanted to kind of add to what Dion said, which is that what this study really is a snapshot. And since we don't know anything about, or we know very little about the actual interactions and this is also an exploratory study that charts new territory. In addition to the fact that trust changes over time, like Ani mentioned very appropriately, I mean, people coming in, to these encounters that Deb is studying also bring different levels of trust with them. So there's not just a post factor, confounding factor. There's also a pre-confounding factor. And again, this study is not able to control for them because it really isn't the kind of longitudinal study that you want to see in these settings. What it is going in, taking a bunch of impressions and coming out. And so I really want to kind of emphasize that looking for confounding factors is not necessarily the focus of the study, because they simply cannot be controlled for in a short duration observational study of this nature.
Thank you. Other questions? Yes, Dana. Mm-hmm. Mm-hmm. That's a great question. Of course, I have to submit a proposed observation guide and an interview guide when I go for IRB approval. And I think that part of what I understand, and not having gone through it before, but what I've learned from speaking with others is you have to do a little bit of education. I think it's better than it has been in the past when they weren't used to seeing so many qualitative studies. But educating the IRB folks who are looking at your proposal that the nature of qualitative research is to be iterative, and that you want to have that feedback loop where as you learn things, okay, I may tweak that question a little bit. I think, and this is kind of trying to read their mind, which is a dangerous thing, but what they're looking for is material changes that you would make. And certainly if there was a material change, I'd have to submit a modification to it. But I think if I can convince them that there might be slight changes to the wording that reasonably would not be perceived as material. Any thoughts on that? Or?
If I understand you correctly, so you're submitting what you believe may be your questionnaire.
Right.
Really validating that to your initial observation.
Right.
Modifying it. And because the may not be substantial, you may be able to skip a full IRB line. Which is kind of what I thought you might be doing, but I just wanted to ask you. I think that input.
A bunch of the questions are well established.
Mm.
So those aren't going to change. You're not going to
Right.
change the existing scale.
No. Right. It's primarily the what am I looking for in the observation, which really is there's no interaction there with the patient. But the interview guide is what is likely to evolve over time. Dr. Gorman.
Just to make a wonderful presentation. Very much look forward to your results.
Thank you.
Lots of stuff that I'll email you. But with respect to this IRB question, I want to say the IRB is our friend. And so I think that if we don't know what we're going to ask patients, and the IRB would like to see what we're going to ask them, then another strategy is simply to say, I'm going to figure this out and I'll file a mod. And I think because you really don't yet know, right? And I think they want to know, and we want to know that they think these are good questions to ask and so forth.
Absolutely.
So I think that's another way to do it, is just say, I'm applying for this part, and I'm going to do this qualitative part, but I can't send you the questionnaire any better than this. And I'll send you a mod when the time comes, which is another way to do it.
Great. Thank you. Yes, Dr. Eden.
Was able to catch.
Thank you.
I have in the past sent a script for qualitative over it, and sometimes the questions are fairly general, and then we'll note and we'll probe appropriately, with follow-up questions. And I haven't had to resubmit the script every time there's some minor change in the follow-up question. So I think just how you word it could make it easier for it to already include whatever that probing or follow-up question is.
Thank you. Yes.
Yeah, so this might,
Bob.
this might be beyond the scope of your study,
I think that during that first phase of observation, although I'm primarily focused on the clinical encounter, there will be hallway conversations and the opportunity to ask some of those questions in sort of a discovery mode as part of the actual structure of the study. It is beyond the scope. I really want to stay focused on the patient, what the patient thinks. And that's a very rich area for future research. Thank you for the question. Bob, by the way, is a former scribe. Yes, Virginia.
Is the gender of the scribe denoted in your study?
It will be. Good question. Robbie is the manager of the scribe program here at OHSU, and he's just saying that all of the scribes currently in the department are female. Thanks. Have we had male scribes in OBGYN?
I think there's been one, but we purposely select female scribes for the second, given the female-only population.
Mm-hmm. Thank you. Other questions? If not, thank you very much. I appreciate your attention.
I think you're the first person I've seen thank bus drivers.
You probably know why I do that. I get a lot of reading done on the bus.